All right, great. We will go ahead and get started. Good morning, good afternoon, and I think possibly good evening to some of our listeners. I'm Stacy Hanna. I'm the Director of Research Engagement at AVAC, and I'm just really excited to welcome everyone to our webinar today, The Power and Pitfalls of Modeling for COVID-19 and HIV. I am actually just going to do sort of a quick introduction and go through some housekeeping, and then hand it over to our colleagues from a number of colleagues from Avenir Health who are going to take us through the agenda. I think it's going to be just a really nice overview, and hopefully have some time also for some good discussion and questions with everyone. So yeah, I mean, just, I think modeling these days needs no introduction. If anyone is sort of paying attention to the daily news, it's just so interesting to see that that modeling is really in the mainstream, and is really being a sort of a foundational tool as we deal with the current COVID-19 pandemic. And I think we've all seen sort of, again, really the power that these tools have, and how we're really relying on them to kind of help us understand how this pandemic is going to play out, but have also seen sort of the drawbacks and some of the limitations that they do bring. And so Avenir Health and AVAC thought that this would just be really interesting content to bring to this wide audience. And we do know that a good number of people have registered and are on the line. So again, just really looking forward to hearing from the folks at Avenir Health. Avenir Health is an organization that for a number of years is focused really on building these tools, modeling and other types of tools to assist with a kind of a wide range of public health and policy programming. And Avenir has done a lot of modeling specifically in the HIV/AIDS space, and I think we all know that modeling has been used in our own field of HIV and AIDS to do things like predict, to set things like 90-90-90 targets, and really to look at the impact that various interventions can have on the epidemic. And Avenir is a partner of AVAC through our CASPR program, the Coalition to Accelerate and Support Prevention Research, where we're looking at, again, kind of modeling around sort of various aspects that the R&D agenda can have on HIV and sort of the response to that epidemic. So yeah, again, just really excited to hear about all of this from you all at Avenir. Before I hand over to you all, just the logistics, I think probably people are familiar with these Zoom webinars. Everyone is right now on mute. We do really encourage you, again, we've got some time set aside at the end for some discussion, so we'd really encourage you to use the either the chat or the Q&A box there at the bottom, whatever you're most comfortable with. We'll be monitoring both of them throughout the call, to write in your questions as you have them, and we'll be again keeping track of those, and hopefully have time at the end to address many of them. If you we would love to hear voices from people. If you would like to chime in and ask your question audibly, just please let us know. We're happy to take you off mute so you can chime in. Again, kind of send us a note and we can make that happen. I believe that's all for logistics. So great. So I think I'm going to hand over to John Stover from Avenir Health. John is the vice president and the founder of Avenir, and has just many years and a wealth of experience in modeling and building these types of tools. So John, I think over to you.
Okay, thank you, Stacy. So if I could have the next slide, I thought we would start by giving a brief introduction to the COVID-19 models that are in use today and discuss a little bit about the types of the models. And then we'll go on to the other sections in the question and answer session. So next slide, please. Next. So as Stacy said, modeling for COVID-19 has been all in the news from the very first days in January, when models were predicting that we might see over 1 million deaths due to COVID in the US, to today where models are helping to guide strategy. Slide, please. So why use models? So the first one is to understand the potential magnitude of the epidemic. How bad might it get? Is it something we should worry about? We should worry a lot about, or not be too concerned about? And then also, once we have some basic understanding, how do we expect our actions or different assumptions of the transmission to affect projections that we make going forward? So most to do these what if type questions. Next slide, please. So most of the models that you'll see being talked about are what we call SEIR models. So these are models that look at the population in 4 main categories. Those that are susceptible, they've never been infected by the virus. Those that have been exposed to the virus, so they have the virus but are not yet symptomatic. Those that are infectious, so they could infect other people. And then finally, those who have recovered from the virus. Most of the models that I'm going to talk about, although not all, were originally developed to look at seasonal flu, because we know that the seasonal flu varies each year in terms of severity and reach and speed. So a number of different groups have been involved for 10 years or so in trying to model seasonal flu. So they've developed these SEI models for seasonal flu, and when COVID came around, they quickly tried to adapt them to COVID. Next slide, please. So in order to make the model dynamic, we have to have a mechanism by which people move from the susceptible category to the exposed category. And that depends on the number of people that are infectious in the population. When there's nobody infectious, nobody else is going to get infected. But the more infectious people you have spreading the disease, then more of the susceptible people will catch the virus and move into the exposed period. So the rate at which that happens is called R0. So that's essentially how many people will be infected by one infectious person. And that depends on how long the infectious period lasts, 3 days, 4 days, 5 days or so. It depends on how many contacts that person has with susceptible populations. And to some extent, it depends on the transmissibility of the virus, how likely it is to transmit from one person to the other. So various values of this R0 will give us epidemics of varying speed. Initially, most of the models looked at the data from Wuhan, because there we had data very early on that showed us pretty much what was going on in the early course of the epidemic. So models were using those data to try to estimate this R0 value. And therefore, most of the models were projecting epidemics that looked a lot like Wuhan in the early days. But everybody recognizes that that force of infection, that R0, may vary, first of all, from individual to individual based on the severity of the infection, but also by different geographic locations, because there are different contact rates. Some people have lots of contacts during a normal day, other ones don't. It could be by age, by whether people have to commute to work or not, transportation patterns, even by the day of the week, because weekend contact patterns are very different than during the work week. So all of these things can affect that R0. The other thing are things that are unique to COVID, such as when somebody becomes infected, how long until they develop symptoms and become infectious. So initially, we thought that this latency period is about 6 days, and people only transmitted when they were infectious. Now we know that people can transmit before they show symptoms. So that's the hash line there showing exposed also enter into this, which makes COVID so much more difficult than some other viral diseases. And then we have the recovered group, where once somebody's passed through the infection and survived, they're recovered and they're no longer susceptible. And we assume that they're no longer susceptible to reinfection and also no longer transmitting the virus. However, we don't really know whether this recovered period truly protects a person from reinfection or how long it lasts. Almost all the models I'm going to talk about right now assume that once you've recovered, you're immune from transmitting and from acquiring an infection. But I'm not sure about that, and that's going to be important going forward. Next slide, please. So most of the model elaborates in infectious category to divide it those with severe cases, those with mild cases. Mild cases might show very few symptoms, not need hospitalization, and recover relatively quickly. Severe cases take longer to recover, might hospitalization, and in the most severe cases might require intensive care, which could lead to death. So we also need then to understand the mix. How many cases will be mild? How many cases will be severe? Of those severe cases, how many will need hospitalization? How many will need ICU? So different assumptions about these rates are one of the reasons that you see some different forecasts coming out of the different models. Next slide, please. So I don't know, my last count, there's probably 20 different models that have been released in some form to the public of these SEIR models. In the United States, the ones that have been most publicized and probably most watched are one from Imperial College, which their initial model looked at the US and UK. And this is an agent-based model that simulates 1 million individuals, given sort of characteristics of the population simulated, and follows those individuals over time as they become infected, have contacts with other people, and recover, and et cetera. The other models shown here are all we call compartment models. And instead of trying to simulate individuals, they simulate groups of individuals. So men 15 to 24, for example, as a group. The Imperial College model looked at the US and UK. The model from Columbia University, which has been, I think, instrumental in informing US policy, does estimates by county, which is a big help. Northeastern University also has a model that's been used to validate a lot of models. Universities has been putting out results from their or so major metropolitan areas across the US. And then IT Hartford Healthcare has a state level model, which I know has been very informative about policy in the state where I live in the US and Connecticut. And then internationally, there's a different Imperial College model that's not an agent-based model, but a compartment model of a different group at Imperial College, but clearly with a lot of communication back and forth, which is a very detailed model by age with very detailed contact matrices. These are by age and sex, how many people have contact with what other age groups during the normal day. The second one is the Mayher model at University of Basel. It's called the COVID-19 scenarios model. This is an aggregate model that has an easy to use web interface. So it's not as complicated as, say, the Imperial College model, but because it has an easy to use web interface, a number of countries have picked up on it and used it to modify the input parameters to match the situation in their country and do some basic scenario. London School of Medicine also has a model and just recently released a web application for it that allows you something similar to the Basel model and it focuses on looking at different amounts of social distancing and how it might affect the course of the pandemic. And then finally, I should mention there are a number of country-specific models out there. Ones that I'm aware of, South Africa, several groups in Kenya, Malawi, have all been using local talent at universities and research centers to develop models specifically for their countries. The thing that all models have in common is they all follow this SEIR, the susceptible, exposed, infectious, recovered way of categorizing the epidemic. Next slide, please. So there's a second type of model, which are statistical models. So in a statistical model, we start with information such as shown in the graph in the top right about number of new reported cases of COVID. And then we fit a mathematical equation to try to explain or try to match that pattern. Now in the chart you're seeing there, the line just fitting a curve to that to try to, you know, the shape of that epidemic. In the statistical models, you'll see they try to explain the indicator, such as, let's say, cumulative number of deaths, as a function of inputs. So how long has the epidemic been going on in that location? Where is that location? Is it a metropolitan area or a rural area? Has that area introduced social distancing? What is the age distribution of the population? So taking those sort of socio-demographic factors into account in a mathematical equation, can we predict the cumulative number of deaths over time? And then hospitalizations might also be predicted from cumulative deaths. So notice that these models don't have an underlying structure that talks about individuals becoming infected and recovering. So they're not worrying about all those intermediate parameters about how long you remain infected and how long it takes to recover. But all those are somehow inferred. Now, in order to do that, it requires some data. So the IHME model from the Institute for Health Metric Evaluations, which has received a lot of press, certainly in the US and guided US deliberations, has a very nice website, and it has results state. And it was one of the first to have such a nice website with regular updates. So that in and of itself made that model very accessible. And because IHME itself has a good reputation, that model quickly became one that people were looking at. Even if they didn't understand how the model was constructed or how it worked, it was so accessible that it had immediate influence. But it's important to understand that the early versions of the model needed to be based on some data. So they took data from locations where the epidemic got an early start and had already, in many cases, peaked or at least, come close to the peak, so that they could figure out from their statistical analysis what that shape of that curve looked like. So they used data from Wuhan, from some regions of Italy, such as Lombardy, that had early epidemics, a few regions of Spain, and also King County in Washington State in the USA. So the early IHME models essentially were predicting that the epidemic, once it got started, would follow a pattern similar to what we saw in Wuhan and some regions of Italy, excuse me. So you may have noticed that the early estimates from the IHME model were initially a bit on the high side, around 100,000. Very quickly, that came down to 75,000 cumulative deaths over the course of the first wave of the epidemic. And then just a few days ago, they radically adjusted that from 75,000 cumulative deaths to 135,000 or so. And why did they make such a big adjustment? Well, now in the US, there are many places that have reached their peak and started to come down, so they recalibrated their model on those new data, and that's what gave them this new set of projections. Next slide, please. So why do models differ? So this is an interesting chart that was produced by the New York Times a few weeks ago, where the black dots and lines show the reported AIDS deaths through, I don't know what it is, April 23rd or something like that. And then the colored lines show projections of AIDS deaths from various different models. So why are the projections so different? Well, there's a lot of things you need to look at if you look at a chart like this. Look at the Imperial College model. It's a green line. It looks like it's just completely sort of unrelated to the actual data. Well, that forecast from the Imperial College model came from several weeks earlier, before we had all this data on reported deaths, and also was done under the assumption of no social distancing. So of course, it has a higher projection. The other models, that each one of these is detailed in terms of when the model projection was taken, but that the red line you can see there for the Columbia model, that is very different from the reported deaths, because in the Columbia model, they tried to estimate how many actual deaths there have been from COVID, not just those that have been reported. So they're not believing that black line. They're including deaths that have happened that didn't yet get classified as COVID deaths. So that's why they have a much higher thing. And then for you can see the IHME model, which is updated on every several days. So of course, it's fitting pretty close to the reported deaths. Next slide, please. So I'm going to stop there as just a background on how these models are constructed and why they may differ, and turn it over to Nadia to talk about sort of the next step in all this. Nadia?
John, before Nadia starts, there were a couple of clarifying questions that came in. I wonder if you could just address them really quickly.
Sure.
So the first one was, have any of the published COVID models estimated outcomes that assume that the recovered population might become susceptible again?
So not that I've seen. I think all of them are assuming right now that people stay recovered.
And then the other question was, are asymptomatic and moderate cases taken into consideration in the SEIR model?
Yes, they are, but this is an area of uncertainty, because what we have is information about reported cases. We suspect that there are actually many more cases of mild disease that don't get reported. So that's the reason that some countries are rolling out these antibody tests to try to test a slice of the population and find out how many people have been infected but never had a serious enough case to report. So as we build our understanding about those cases, the models will adapt to that information.
All right, great. Thanks a lot. Nadia, please start.
Thanks, Catherine and John. So to build the capacity of CASPR partners around mathematical modeling, Catherine and I designed a modeling capacity building module, which was converted into a 4-part webinar series that we offered last year. This module and the webinar series builds on material by John Stover on how models can be used for evaluation, and it also covers how models can inform HIV prevention and treatment policies and the decision-making process. We held the webinar series last year, and it was really successful, so we decided to convert the material into a course on the Engage platform. Next slide, please. Or actually, I can stay on this one. The first course, sorry, we can go back. The first course, as it says here, is going to be starting in mid-May and already has 14 participants who are enrolled. So we're looking to recruit a few more participants, and if you think you might be interested in being part of this first cohort, please follow up with me by email after the webinar. I'll share my email in the chat. So I'm just going to give you a very quick overview of what you can expect to see in the course in the next couple of slides. The course was designed to build the capacity of advocates and of journalists to understand what mathematical modeling is and to help them to understand the value that it can bring to their work. It includes 6 lessons that are made up of short, about 10 to 15 minute pre-recorded and self-paced videos There are also a couple of assignments, some case studies, and lots of resources. And we also have some COVID-19 modeling resources that you might find useful and interesting. Next slide, please. So the first few lessons help participants to really understand what mathematical modeling is and the role that it can play in HIV prevention policy and planning. These lessons also explain some key terms that are often found and used in modeling. And here I've just shown some screenshots of the many resources that we have in these first two lessons for participants. We can go to the next slide. The next few lessons feature some case studies to really showcase how modeling has informed HIV prevention and treatment policy to date. So they feature interviews with AVAC's Mitchell Warren, who describes some of the most influential modeling to date. And he also provides some really great advice for advocates and for journalists about using modeling in their own work. We also have interviews with Dr. Gemelli on the role of modeling in the rollout and the expansion of voluntary medical male circumcision, and with Dr. Ruben Granich on modeling that eventually led to treatment as prevention. We can go to the next slide. In the last few lessons, these ones really give participants some practical experience in using some key questions to better understand modeling that they might come across and how to interpret the findings from this modeling in their own work and their settings and for their own advocacy priorities. So I hope that this gives you a little idea of what you can expect in this course. As I mentioned, the first course will start in a couple of in mid-May. So if you are interested, please contact me by email after the course, and we'll make sure to try to get you hooked up into the first cohort. Thank you.
Thanks so much, Nadia. This is Catherine Kripke from Avenir Health. I'm also part of the CASPR project along with Nadia and John. And we're going to now have a little bit of moderated discussion with John. I'm going to start off with a few questions, but I did see a question in the Q&A, and Nadia, maybe you can just answer this really quickly. Is there any cost for participating in the course?
There is no cost for participating in the course. The course is available on a participatory platform called Engage. So you just need to register for an account, and you will have access to the course once it's live.
Great, and you do not need to be a part of CASPR to be a part of the course. It's open to anyone who's interested. So, so John, if you can unmute yourself, we can have a little bit of discussion. I was wondering, you know, you have a little bit of inside scoop on the COVID models that are being used nationally in the United States and how they're informing policy. Are there any insights that you can share about that? Which models are, you know, have the most credibility? What are some of the problems with some of the models? Anything, any inside information you want to share with us about that?
Sure. So first of all, just to say that I mentioned earlier that many of these models were developed within the last 10 years, actually, originally for seasonal flu. So there has been a working group established by the US Centers for Disease Control, CDC, on seasonal flu modeling that has been collaborating across about 10 different institutions for the last 3 or 4 years or so. So that collaboration has continued as these modeling groups have moved into COVID. So there's a pretty good understanding in that group of the different approaches that the models are taking and the strengths and weaknesses of each, etc. So the models are not all doing the same thing. Some of them are trying to model at very local levels like counties or cities. Others are modeling at state levels. Others are focusing on modeling at country level. So there's a great variety. So in terms of which models have had the most influence, I think it depends a lot on where we are in the epidemic and what you're looking at. I can say that for the United States, as well as for the UK, that Imperial College model had big influence early on. in the UK, it's credited with convincing the UK government to institute the lockdown. And in the US, certainly those early estimates that there could be over 1 million deaths if we didn't take any action were also key in terms of getting started with social distancing and lockdown procedures. The IHME model has also had, I think, a lot of interest within the US, the White House Coronavirus Task Force, partially because it was the first one really to put out detailed state level estimates. And early on, the task force was focused on trying to figure out where the hotspots would be, how to increase hospital capacity, et cetera. So that early information at more local levels was very important. Then as the epidemic evolved, I think all countries got into the issues of hospital capacity. Do we really, the models are telling us that our hospitals are going to be overwhelmed. What can we do about it in terms of expanding bed capacity and personal protective equipment? So the models, I think, were used quite a bit for that, for trying to project even just 2 to 3 weeks in advance what the hospital needs were going to be. And every location was scrambling to increase hospital capacity by doing temporary hospitals, to find places to buy masks and gowns and shields. So I think those two models, certainly in the US, had a lot of early impact. And the other Imperial College model was the first one that came out with projections at country level for countries outside the US and Europe. And those projections were quite startling because most of them were projections of what would happen without any policy reaction. And it certainly, I think, convinced a number of governments to start lockdown procedures even before they had seen very many cases.
Thanks, John. Is there anything else you want to say about models for outside the US, especially for African countries? Are you seeing, are there more models coming online?
Yeah, definitely there's more models coming online. And as I mentioned, the other thing is that, most African countries have some pretty good people at local universities that have been involved in various infectious disease outbreaks, whether it's flu or Ebola, malaria, or dengue fever, other things. So there's a lot of expertise in each one of these countries to both evaluate and use models that are publicly available, but also to build their own models. The actual building of a model, of an SEI model, is not all that complicated. The complicated part comes in analyzing the available data to try to figure out how it relates to your country. And the unique thing about COVID is the contact matrix. To really get it right, you need to figure out, so if children go to school, how many other children do they have contact with? Where do they go after school? So if they catch the virus, who might they spread it to when they're out of school? Same thing with parents, et cetera. And then the whole issue of contacts between urban and rural areas is something that's probably going to define a lot of the characteristics of the epidemic in African countries. And I think that's where the local researchers are going to really come to the fore to figure out how to do that best for their environment.
Great. And have you seen any modeling about interactions between HIV and COVID?
So we at Avenir, along with 4 other groups through the HIV Modeling Consortium, have been and are just about to release a paper on the impacts of COVID on HIV services. So if because of social distancing or because of strains in the healthcare system, people are not able to get their antiretroviral drugs, or not able to get condoms, or PrEP, or get circumcision, how is that going to affect the HIV epidemic? So we have, as I said, a paper coming out on that shortly that essentially shows that the impact of a short-term lockdown on new infections is probably likely to be relatively small and transitory. But the impact on if people lose access to antiretroviral drugs for any significant period of time has the potential to, at least double the number of AIDS deaths happening in 2020. There's not been so much work on the other way. We're speculating, are people living with HIV more susceptible to the virus or more susceptible to COVID or to a severe illness? And we don't have any information on that at the moment. There's some speculation that if they're already on antiretrovirals, they may actually be somewhat protected against catching the virus, but we don't really know. It's all speculation.
Great. And John, what kind of parallels have you seen between HIV and COVID modeling?
Well, lots of parallels because it's a lot of the same people are involved. Debbie Birx, Ambassador Debbie Birx, who's heading up coordinating the White House Coronavirus Task Force, is the director of PEPFAR, so she has direct experience with HIV. A lot of the folks doing modeling are from HIV, and others are not, but all infectious disease modeling shares a lot of characteristics. So I would say that there's a lot of commonality. One thing that for a long time, people modeling HIV have been including estimates of uncertainty in their projections, which haven't been very widely focused on. But with COVID, because there's so much uncertainty, I think people are beginning to understand, that all these model projections come with sometimes very large amounts of uncertainty, and they're starting to take notice of that.
John, there was just one clarifying question on what you said. Did you say that if people don't get their ART, it will increase the HIV rates because of the transmission?
So mostly the effect is on mortality, that people, when they go off ART, they're no longer controlling the virus, so their CD4 counts will decline and can lead to rapidly to death. There is also an impact of new infections, of course, because if people go off their drugs, their viral suppression will decline over time, and there will be an increase in new infections, sure.
And here's another interesting question from one of the participants related to what you just said, John. Most of the COVID-19 epidemic data came from China, Western Europe, and the US. How is it possible to apply those data to African settings where there's a substantially younger population and population density is maybe much higher in some places, which might lead to greater household or community transmission?
Yeah, so that's been a challenge for these models because in most of the African countries, the epidemic is just in the very early phases. So we're not really sure whether it will follow the Chinese or the European pattern or not. Although there are a few countries such as Burkina Faso where seems like they may already have moved through an early phase of the epidemic with very few infections. Some of the models, such as the Imperial College model, put a lot of effort into collecting information about contact patterns. So there have been several studies, one of them in Manicaland in Zimbabwe, for example, that several years ago did a study of contact patterns of the population, who they have contact with on a normal basis, and transportation routes, et cetera. And that was done in the context of HIV, but that information is also very important for understanding COVID. So the Imperial College model collected all of that information, and it's built into their model for their projections for the African countries. Almost all the models have some type of age structure in them. So they are using the age structure information. And because we know about mortality rates and transmission patterns differ by age, that part can be incorporated relatively easily. Probably the difficult part is, yes, how different are contact patterns in major cities in Africa versus, say, Europe? We have a little bit of information about that, but not as much as we'd like. And then secondly, how about rural areas where the contact patterns could be very different? and then the contact between urban and rural areas. We know that differs a lot. Whereas in Southern Africa, the contacts between urban or rural areas and urban areas are relatively frequent, and maybe less so in East Africa and West Africa.
Thanks. And there's a number of questions about models that are used to influence US policy. So one question is, the Washington Post reported on May 5th that the White House is relying on the so-called cubic model, which suggested that deaths in the US will end soon. Is that the same as the IHME model? And can you address the methodology for that model? How reliable is that?
So yes, as I mentioned before about IHME, they recently updated their statistical model based on new information that they now have access to about how the epidemic is transpiring in various US locations. Before, they had Wuhan, and as I mentioned, Lombardy in Italy and a few other places, which told us what the epidemic looked like under early rapid spread and then fairly quick government action for social distancing and lockdown. So they were using those patterns in the US. Now they're realizing that the patterns are different here. The rate of early increase is a little bit different depending on location. And our patterns, our response in terms of social distancing and lockdown have been somewhat less severe than in Wuhan, for example. And the third thing I think is the heterogeneity of the epidemic in the US. So everybody was initially focused on Washington State, and then New York City became the major focus, but actually it's spreading at different times and different rates throughout the country. So that's the reason that they made that revision. Qubit model is just an Excel-based tool, curve-fitting tool that tries to fit to the data that's becoming available. And they're depending on the assumptions that you make about what type of curve to fit to those data, you can get different projections. So I'm not hearing, Catherine, are you?
Oh, sorry, I was on mute. Just one more question for you, and then I think we're going to change topics. So in the US, many states are reopening. What good models are there for the effects of that combined with diagnostic testing and contact tracing?
So a number of the models have looked at this, as you might expect, because very early on this became a question. Most of the models suggest that if you reopen too early, that there will be a second wave of the epidemic, probably in the fall, although the timing is not really sure. So many of the models have looked at, can we, if we do open in some senses too early from an epidemic standpoint, and there is a bit of a second wave, what indicators can we look at to try to understand if we have to impose a second lockdown, and where? So the models have been looking at, can we look at hospitalizations or new reported cases to give us an early indication that the virus is surging in that location we need to look down. Testing, of course, is one way to do that. If we have widespread testing in the population on a regular basis, we can use that to indicate what looks like the virus might be resurging, or we can do another lockdown. One of the early projections from the Imperial College model was this sort of phased approach where you relax things for 6 weeks or so, and then you detect that the epidemic is resurging, so you lock down again for 4 weeks, then you relax for 6 weeks, and sort of a phased approach until, a vaccine becomes to save us all.
Great, thanks. And John and also Nadia, can you just comment briefly, I know that this is covered within the course, but can you comment briefly about some pitfalls of modeling that advocates should be aware of?
Well, maybe I'll start. You know, the first pitfall that's obvious is never believe the models because they're a mathematical representation. So you always need to try to understand what information was informing the model. So if you're using a statistical model like the IHME model, those types of models are usually going to be pretty good in the short term because they're using the latest data we have with their models. But they might be terrible in the longer term. So trying to use IHME model to predict what's going to happen in September, IHME doesn't even do it, predicting the first wave. So you have to understand that an SEIR model that looks at the underlying dynamics might not be as accurate in the short term as a statistical model, but would be better able to capture things like a second or third wave of the epidemic because it's modeling the underlying dynamics.
Nadia, is there anything you wanted to add to that?
The only thing that I would add is just that, so on the screen right now, at least what I'm seeing on the screen are some key questions that we came up with that are covered in the course. And these questions will really help you to look at the modeling that you come across and to think about what the assumptions were, what were the limitations of that modeling, in what context was it applied, who funded the modeling, and all of these questions will help you determine how you can apply it in your own context, in your own setting, like whether the modeling is generalizable in your particular setting. And these questions might also help you to really determine which modeling that you should be going with.
Great. And I'd like to address the next question to Yvette. And also to some of the attendees on our webinar. Maybe you can also either raise your hand if you want to comment on this or type into the chat. So how can advocates examine and, if necessary, challenge modeling studies?
Okay, thanks, Catherine. Good afternoon, everyone. Yvette Raphael from South Africa. I think when it comes to modeling, it's something that advocates really, really needs to just still unpack and get to understand how it happens. And I think the course that Avenir Health is offering is one of is a start. I think what we struggle with mostly as advocates is that these modeling studies are never published, so we would not be able to just get access to a modeling study as advocates to engage meaningfully in. And sometimes we also feel so overwhelmed by policymakers and our governments just instructing us what to do. And I'm glad this is both on the HIV and the COVID presentation, because you can imagine for us as advocates having to explain to communities how are we modeled on something that happened in Wuhan, and people now suddenly have to be locked down, and we as advocates also struggle to understand the issues or reasoning behind modeling, and also the issue around why governments do modeling most of the time is based on budgets, and advocates need also to get that understanding and engagement on how to strike the balance between cost and human benefit, and also to build relationship. I think one of the biggest things that is lacking in advocacy and advocates engaging with modeling is that cross engagement between modelers. I don't even know, should I call them modelers or people who do modeling and advocates, so that we can have a relationship to engage some of the policies that our governments make, and how to interpret and identify when modeling is happening. Like, for instance, with the COVID situation, we just hear this number of people died in certain countries, and for some people in our corners, we're like, now And I'm glad somebody spoke about age difference and how Africa has a younger, population. But the question was, how does that affect us? How does that make it the same case as in Africa? So I'm very excited with how the course will happen, how it happen and help us. But also, I would think it would be a start for us to actually build a bridge between advocacy and modeling, so that we get to understand and also have modelers help advocates to build our case in some of our advocacy. Thank you.
That's great. Don't mute yourself yet, because we've got some more questions for you. And also for the AVAC, there was actually a question directed towards AVAC about how AVAC is helping to develop advocacy messages that combine both this information about modeling of the pandemic along with, budget allocations that should be used. What is AVAC doing, and what are other advocates doing in this area? Go ahead, Mitchell.
Oh, I don't know if Stacy was on mute. Thanks, and I realize we're close to the top. I'll just say that is a great question, and I think this webinar is one piece of the puzzle. The models, as John and Catherine and Nadia have explained on this call and have taught all of us at AVAC, they're just simply tools that can be applied and need to be applied responsibly. And I think we're working really hard, as we have with many of you on the line, looking at how to translate HIV models around targets, around resource allocations, to really try to get ahead of that with the COVID modeling and being able to understand and really fundamentally ask the right questions. And I think, again, what we've all learned together and what the course really does so nicely is how do you not just accept models because a number comes out one end, but rather how do you interrogate it to understand the so what and the what next in what the model is describing. And we're working hard to both build that capacity for all of us to understand models, and that's the course on the new engage.avac.org platform, as well as really trying to figure out how to craft the right advocacy messages. And just one thing related to what John said earlier is, how do we do that so that we get the best possible COVID response while also not ignoring or neglecting the HIV response? We've had such great gains in the HIV response, and I'm so glad that John and the Modeling Consortium are putting out this new paper about the implications on service delivery, because doing well against one epidemic and failing on the other doesn't help us in global health terms. I think that's where connecting modeling with advocacy is so powerful, so that we can really articulate how to craft the best possible programs. And so I think Yvette described it beautifully, what happens at the country and regional level, and we're looking to catalyze that and really welcome any and all queries after this webinar to how to do that better.
And maybe we have a really good question here. Maybe any of the panelists, Mitchell, you can start, but any of the panelists, I think, can weigh in on this. What actually increases the likelihood that models will influence decision making?
Well, I'd love to hear what a real modeler says. So maybe for John, I will just say that I think what's critical is that we really understand what's gone into that model and what's come out and what the implications are. So I think for me, the real issue is not to focus only on the curves and the numbers, but to understand what assumptions went in so that we can understand what are the implications coming out, and really see it as an informative piece of that puzzle is I guess how I look at it. But I would love to know how a modeler thinks.
John, do you have any thoughts, or you've been working in this field for so long?
Sure, I would say three things. One is the credibility of the institution developing the model. A second one is timeliness. If the model is producing estimates when decisions need to be taken, it's got a lot better chance of having influence than if it comes out 3 weeks after the decisions need to be taken. And the third one related is policy relevance. Is the model providing information that's required for the decisions that are being made? So is it providing information about when you can relax restrictions, et cetera. I can tell you that the U.S. White House task force, early in the epidemic, once the task force was established, spent quite a bit of time interviewing each one of the major models that were putting out results to try to understand, how the model was developed, what the basis was, the data that went into it, how they were reaching their results. Did they include things like seasonality and transmission of non-symptomatic patients? So they really did their homework to try to understand which of these models they could trust.
Okay, so we're pretty much at the top of the hour. Before we close, I just want to mention that AVAC will be following up with more details about the course, including Nadia's contact information for anyone who has questions. We are also going to be sending out a short brief that outlines the, gives some key information about COVID models, as well as the webinar recording for this group. So I think we will just close there. We got a couple more questions, and if we can, we might see if we can send out answers to those along with the webinar information. Thanks, everyone. This has been really a great discussion.
Thanks.
Great.
Thank you.